Welcome everyone to Ask the Doctor, Depression and Anxiety. My name is Cindy Beck and am a NAMI board member and I work for the California Department of Education. I would like to introduce our speaker, Dr. Farokhpay, Assistant Professor, Psychology and Human Behavior, School of Medicine, University of California, Irvine. Dr. Farokhpay is a board-certified adult psychiatrist who has been practicing for over 10 years in the Orange County area. He completed his undergraduate studies at UC Irvine with a bachelor's degree in biological science, then attended medical school at UC Davis. Upon deciding to pursue a career in psychiatry, Dr. Farokhpay completed 4 years of residency training at UC San Diego. After graduating from residency in 2011, Dr. Farokhpay moved back to Orange County, where he resides and practiced serving the community in which he grew up. For approximately the first 7 years of his career following residency, Dr. Farokhpay worked with patients from 18 to 65 years of age in various psychiatric hospitals in the Orange County area. He has a passion for inpatient psychiatry and working with patients who are experiencing acute and long-term severe mental health conditions. For the majority of the 7-year span, Dr. Farokhpay served as a medical director of the Royal Healthcare Hospital in Santa Ana, California, working both with short and long-term patients. To complement his passion for inpatient psychiatry, Dr. Farokhpay, for those same 7 years, worked in intensive outpatient mental health programs for young adults age 18 to 26 called the STAY, STAY process. Here he was able to work closely with a large team to serve young adults who were dealing with severe and persisting mental health conditions. In that time, he has developed a special interest in the young adult population and hopes to continue this work in the future. In 2018, Dr. Farokhpay decided to transition to UC Irvine to join their Department of Psychiatry. He wanted to further his teaching and education interests by working with psychiatry trainees and medical students. For the last 3 years at UC Irvine, Dr. Farokhpay has been one of the teaching professors in the UCI psychiatric unit. In addition, he teaches and sees patients in their clinics. Dr. Farokhpay provided teaching seminars to psychiatric trainees, as well as being the associate residency directors for the UCI psychiatry training program. Please help me in providing a warm welcome for Dr. Farokhpay. Thank you.
Thank you very much, Cindy, for that introduction. Thank you all for being here. It's a pleasure to be here. This is my first opportunity to ever speak at one of the NAMI conferences, and honored to be here. And hopefully with the time that we're going to spend today together, it'll be beneficial, fruitful, and somewhat beneficial for you all and for myself as well. Just in terms of the formatting of our time, I'm going to be presenting a number of slides just to cover various aspects of anxiety and depression, and then for the latter half of our time, we will leave it open for question and answers. If you could share those in the chat, and then Cindy and her colleagues will be fielding those questions, and then we can happy to entertain your questions. So speaking of anxiety, my anxiety increased a little bit prior to the beginning of our talk because we're having some technical issues on my end, which prompted us to start late. So certainly it was kind of a good template for what we're discussing today. So to begin, outline of the various topics we're going to discuss. You know, anxiety is a term that's used very regularly. I'm sure you've all heard it before. I want to just spend a few moments actually talking about what it actually is and what it may not be. What is depression? Again, an overly used term, you know, a very commonplace, lay public in clinical circles, and want to cover what exactly is the definition of that term. Then I want to spend a few moments talking about what are called the 4 core emotions to kind of help illuminate what anxiety and depression are and aren't. Then discuss aspects of various anxiety disorders, various depressive features of a depressive disorder, and treatment options by way of medications, treatment options by way of therapy, And then, as I mentioned, question and answer, our time for our question and answers. So getting right into it. So in terms of the word anxiety, again, I'm sure you've all heard that term, used that term in various ways. The real question, well, what does anxiety mean? According to Webster's dictionary, and I wanted to kind of present, various sources on this. It's an apprehensive uneasiness or nervousness, usually over an impending or anticipated ill. So real key here is apprehension, uneasiness, or nervousness. Other aspects of the definition in the dictionary is an abnormal and overwhelming sense of apprehension and fear, often marked by physical signs. I won't read them all, but allude to them: tension, sweating, increased heart rate. And it's really due to an abnormal or overwhelming sense of apprehension and fear about something that is going to happen, a threatening feeling, whether it be internal, external, etc. So what is the definition of anxiety from a quote unquote psychiatric perspective, as in one of our prominent psychiatry textbooks, Kaplan and Sadek? It's a textbook we use often. It's a diffuse feeling, which means it's a generalized, spread out feeling that's unpleasant. It's a sense of apprehension accompanied by physical signs such as headache, sweating, racing heart, tightness in the chest, etc. So the real key here is that it's a generalized feeling of apprehension that can often have physical signs or symptoms come with it. Okay, so what is depression? Again, according to Webster's dictionary, I didn't want to go Wikipedia on this. I just wanted to stick to the classics, so to speak, by way of a dictionary. It's a state of feeling sad. Now, depression, according to our psychiatry textbooks, is a persistent state of sadness that impacts daily functioning, physically, emotionally, and socially for an extended period of time. So just to illustrate, it is clearly a state of feeling sad, but it's a state of sadness that impacts your day-to-day functioning in multiple ways. So it really impacts your day-to-day life, not just feeling down. So again, a state beyond usual quote-unquote sadness. So what 4 core emotions? And again, admittedly, I would have much preferred in a non-COVID era to be doing this in person, be able to engage you guys in the discussion, ask, what do you think I mean by 4 core emotions, etc. But given the medium that we're in, we'll have to just vault right into it. So 4 core emotions: happiness, sadness, fear, and anger. So if you take anything away from our time together today, I want you to take away the fact that despite the various words that are used to describe emotions, emotional states, these really ultimately are the 4 core emotions that we all experience. We all experience in various different ways to varying degrees: happiness, sadness, fear, and anger. I know that some of you may or may not have seen the Disney Pixar movie Inside Out, which is, an attempt to illustrate emotions and what they must be like in terms of characteristics and whatnot. And they do touch on some of this. However, they utilize other terms and things that really go beyond the 4 core emotions. But really, ultimately, at the end of the day, these are the 4 core feeling states. Some can be hybrids of each other, etc. But it's really, this is the 4 core feeling states. And you'll know more what I mean in just a moment. So happiness, some examples: joy, elation, euphoria, excitement, enthusiasm, feeling ecstatic. All of these, if you notice, there are various ways to describe varying degrees of happiness. And, parenthetically, I did want to say, too, is that, when we feel as people, we're not feeling one emotion or the other. We are feeling different types of emotions at the same time. You can both be angry and anxious at the same time, or angry and fearful, so to speak, just as an aside. But happiness, sadness, despair, depression, disappointment, feeling melancholic, bummed out, despondent, all different types of phrases, words that can be used, but ultimately, reside around that core feeling state of sadness. Fear, nervousness, stress, worry, panic, terror, fright, or anxious, or I should say anxiety. Now, these words here, and I'll spend a moment talking about these are all different words that we use in our day-to-day language, I assume, in your workplaces, with your families, or any environment you can think of. And If you notice the commonality between all of them, it's a fear-based feeling. However, it's to different degrees. When one is panicking, something really, really stressful or fearful is happening. When somebody is terrorized, again, to even a different degree. Different than when one says they feel stressed potentially. Stressed that they're not going to pay one of their bills on time, or stressed they're going to be late to a meeting. I was stressed in some ways because we were starting late. But again, the core feeling there is I'm afraid that some bad consequence is going to happen because of X, Y, Z. I am afraid that I'm going to get into this car accident because I just had to slam on the brakes. There's a lot of traffic on the freeway, et cetera, and my life might be in danger. Versus I am afraid that if I don't pay my bill on time, X, Y, Z is going to happen. So it's still, the core behind it is feeling afraid, but we use different words to really articulate that sense of fear. And anxiety is really based in fear. But we'll talk about kind of different ways people experience it. Anger, rage, frustration, disappointment, feeling irate, hostility, aggressive, or aggression, so to speak. So different words that all are an offshoot of anger. So again, to really highlight the point, 4 core emotions. That's it. Me, you, and everybody else, that is it. In combination, varying degrees. So anxiety disorders. Even I just want to say something about the term disorder. As a psychiatrist, I try to shy away from using that term, to be honest with you, because I think it really implies being broken in some ways, or there's something broken about a human being. And I really don't like that. However, it is part of our terminology. And so, it's really, what it really highlights is a pattern of emotional states, sadness, or anxiety that has gone to the level of really impacting somebody's day-to-day life. But to really illustrate the point that anxiety is something we all experience, but a disorder is when various forms of anxiety, nervousness, stress, worry, etc., extend beyond the usual experience of day-to-day anxiety and disrupts our daily functioning. So if I were sitting in a room with you all, a physical room, and I said, who here experiences anxiety? Everybody's hand should go up. Who experiences an anxiety, quote, disorder? Well, that depends to varying degrees and in various forms. So, where does this come from? People who experience an anxiety disorder, for instance. Well, part of it is genetic. There are some genetic linkages, nothing specific, but a sense that there is a hereditary component to it. Nurture, a huge factor. Life events, childhood, home environment, upbringing, all that really impacted, in some ways maybe larger than nature. Various forms of anxiety disorders, generalized anxiety disorder, social phobia or social anxiety disorder, panic disorder. Now, there are some other technical anxiety disorders, but these are the 3 key ones I wanted to focus on, certainly the most common. One thing is a note, you all may be familiar with the book, the DSM-5, which is our book of mental health conditions and how they're described and categorized. It is in its 5th edition. There was a previous one, obviously DSM-4. Just to note, if you've heard the diagnosis PTSD or OCD, those 2 used to be in the anxiety disorders category, but now in DSM-5, they have their own category. Does that mean that they're technically not an anxiety disorder? Not necessarily. People who experience these conditions experience their own day-to-day anxiety as a result of the specific situations stemming from OCD and PTSD, but I still consider them under the umbrella of an anxiety type disorder, a fear-based condition, a stress-based condition, but they're a little different than the other anxiety disorders I just alluded to. So I just wanted to point that out. Generalized anxiety disorder. What are the criteria? It's excessive anxiety and worrying that occurs most days for at least 6 months. People find it difficult to control the worry. And you must have 3 of the following: restlessness or feeling on edge, easily fatigued, difficulty concentrating or your mind going blank, irritability, muscle tension, tension headaches, muscle aches and pains, or sleep changes. People may find it hard to fall asleep, stay asleep, wake up earlier than usual. So there's various ways in which it can manifest. Social anxiety. It's marked fear or anxiety about one or more social situations whereby you're exposed to possible scrutiny by others, like social interactions, being observed eating or drinking in a public place, like, oh, is somebody watching me the way I eat? Are they judging me? I'm at Starbucks, I'm drinking a coffee. Do I look weird to other people? Or, as I'm doing right now, attempting to perform in front of others or public speak, so to speak. The main fear is that you're going to act in a way or show anxiety that will be humiliating, embarrassing, or lead to rejection. Social situations are avoided or endured with intense anxiety. So people, they participate oftentimes in social situations such as this. However, they do it by enduring an intense amount of distress. And the fear and the anxiety is experienced out of proportion to the actual threat. So the sense of the threat is internal. People feel, oh my God, this thing feels so big, when in reality, it may not be as big as it feels inside. That's really one of the key aspects of an anxiety disorder, just anxiety in general, is that it's a inside interpretation of something that seems so much bigger than it really is. People, and for at least 6 months, as you probably know, with some of the DSM criteria, there's a time-based component to it. So it's been happening for at least 6 months in one's life. Panic disorder. People experience recurrent and unexpected panic attacks. And what are panic attacks? If you haven't heard of them, they're stress attacks, anxiety attacks, very sudden surges of fear or anxiety that peak within minutes, usually lasting 15 to 20 minutes. And people experience 4 or more of the following during these types of attacks: pounding heart, sweating, trembling, shortness of breath, chest pain, nausea, dizziness, tingling, fear of losing control. Fear of dying is a common one. Actually, people will say when they experience panic attacks, I felt like something bad was about to happen, or I was about to lose my life, or something to that effect. They're actually very common, panic attacks. But panic disorder is then somebody who has recurrent panic attacks that ultimately result in a persistent concern or worry about having additional panic attacks. So there's an ongoing threat, an ongoing anticipation that, oh my God, I'm going to have another panic attack. So depression disorders, a little more simplistic in terms of the definition. The term clinical depression, what the technical term is major depressive disorder. I frankly don't like the fact that they even put the term major in there. I think depressive disorder or depression would suffice, but it is the terminology that we have to deal with. A major depressive disorder, or clinical depression, or depression, if you will, is 5 or more of the following that are present for a 2-week period or represent a change from previous functioning. One of the criteria, this is really important, is that one of the symptoms in this list has to be either depressed mood or loss of interest or pleasure. So just to note, depression is also something different than usual sadness. Sadness is common. Persistent sadness can be common, following, heaven forbid, a stressful life event, the loss of somebody. These are things that we don't want to turn into a disorder or make a medical issue out of them. It is part of the normal fluctuation of the human experience. However, if it goes on to a certain level, to a certain degree, that is what we are going to call depression, so to speak. The symptoms. So 5 or more of the following present for a 2-week period, and they represent a change from your usual day-to-day. Depressed mood most days, decreased interest or pleasure in activities, significant weight changes or appetite changes, sleep changes, feeling hyperactive or having significant limited movement, loss of energy, feeling guilty or worthless, decreased concentration or feeling indecisive, recurrent thoughts of death or suicide. So 5 of this 9. Where does the 5 come from? There's nothing magic about it. It's really expert human consensus that where they pull their ideas together, get together and try to decide, okay, ultimately, what is the magic line that we're going to call this depression per se. And if somebody hovers around 4, 5, 6 of the criteria, taken in context, that could be called a depressive episode as well. It just depends. Other forms of depression, I'll just say very, very quickly, kind of milder depression, if you will. There's something called dysthymia. I don't want to get into it, but it's kind of a mild, longer lasting version of depression that lasts up to 2 years, if not longer, but it doesn't have the severity of these attributes I just listed. Okay, so treatment. Medications, obviously, it's one of the tools that we have in our toolbox in mental health. I just want to talk briefly about the role of medications in treatment. There's 2 analogies that I like to use. I think our medications are important, and they certainly can be helpful and effective. I do think, are they overused? Absolutely. Are they overprescribed? Absolutely. I think due to marketing, the way pharmaceutical companies in general also advertise, it's almost as if this pill is going to fix your life. And that is simply not the case, but they can be very, very useful tools. So the way I describe the role of medications is akin to somebody who is using an umbrella, the medication being an umbrella, and you use it to prevent yourself from getting wet in a rainstorm. However, you as the person has to hold the umbrella. You have to walk with the umbrella. You have to utilize it appropriately, and then the umbrella can work for you and kind of protect you in some ways. It doesn't change the fact that there's a rainstorm. You still have to do other things like put on maybe rain boots or a coat, but it is one tool that is helping you from getting wet. However, if that rainstorm turns into a thunderstorm, a hurricane, well, that little umbrella is still going to do its job, but it's not going to be able to withstand the effects of a bigger change in the environment. And the reason I bring that up is because often people times will come in and say, my meds stopped working. Well, depression and anxiety medications don't usually work that way. What happens is inevitably life events happen that then overwhelm the ability of that medication to keep things under control. But I want to stress that medications are really geared to keep things under control, like sad feelings, depression, anxiety. They are not going to reverse your life. They're not going to change you as a person. They're not going to, unfortunately, undo events that you might have gone through and change the past. But they can be one tool in the toolbox to help keep your intense emotional challenges under reasonable control, so one can kind of live their life and manage and function. The crutches analogy, that's another analogy I use. If somebody's ever sprained their ankle or broken an ankle, so to speak, you have to use crutches to walk in the beginning. However, when you hold crutches, you do the holding. You hold the crutches. We don't put the crutches on the floor and stare at them. So the point I'm making is that you're an active participator in taking your medication, and the medication doesn't do the work for you. It just puts you in a supportive place like crutches do, where they support you through this difficult time. But crutches don't do the walking for anybody, much like an umbrella doesn't do the work. We have to work with the umbrella to help protect ourselves. One other thing to keep in mind, and this is just a general estimation on my part, the goal of using medication is approximately 30% of the pie, so to speak. So things like diet, exercise, working with a therapist, making life changes. If there's a stressor in your life or one's life that is really causing a significant amount of anxiety, we can prescribe all the medications we want, but they are going to be limited and somewhat powerless in the setting of environmental or life stressors that are happening that are really contributing to this. If one's in an unhealthy relationship and comes and says, I'm having a lot of anxiety due to my relationship, and they want to take medications to help them, the medication can do certain things, decrease levels of anxiety. However, that persistent sense of anxiety that's going on big picture due to the relationship is not going to go away just by virtue of taking the medication. Here's another important thing, I think, with medications that's often not talked about enough as psychiatrists, that taking a mental pill, so to speak, a mental pill, quote unquote, it can be kind of a weird thing. It's different than other fields, aspects of medicine, taking a blood pressure medication and whatnot. So I think it can be off-putting for pretty much everybody. The idea I'm taking a pill to help me feel happy, so to speak. And I encourage, we're not going to get into it much today, but I wanted to just share that and know as a psychiatrist that I really try to respect and acknowledge that. And I think that's important to bring up to your doctors, or if you work with patients or whatever medium you're interacting in the mental health system or experiencing it yourself, to really be real with that's a real thing. But once you can talk about that, share and express, it becomes easier to maybe utilize the medication as a tool and not a happy pill or a fix my life pill or something to that effect. But it's a tough pill to swallow, so to speak. Major concept about medications: there are daily medications, and then there are as needed medications. So daily medications versus what we call PRN or as needed. So now vaulting into medications for a few moments as we round out kind of the slides. There are medications called SSRIs. I'm sure you've probably heard these names before. And the ones in parentheses are what are called the brand name medications. The ones not in parentheses are called the generics. As you probably know, all medications have a generic and a brand name, so we kind of go back and forth. Zoloft, Lexapro, Prozac. These are called selective serotonin reuptake inhibitors. That's what stands for SSRI. So they affect levels of serotonin in the body and in the brain. The time course for these medications to take effect, they're not immediate. anywhere from 3 to 4 weeks to start to feel an effect. Sometimes sooner, but generally 3 to 4 weeks. So these are daily medications that you need to take to build up in one system, or somebody needs to take to build up in one system before it starts to show an effect. SNRIs, kind of a newer version of SSRIs, selective noradrenergic reuptake inhibitors. So they work on two biochemicals in the body and the brain called serotonin and norepinephrine. Boost those levels, so to speak. Won't get into the specifics, but just kind of wanted to present it generally. Examples are Cymbalta and Effexor. Again, probably names you've heard before. Time course to feel the effects, approximately 3 to 4 weeks, assuming somebody takes them on a daily basis. Both of these medications are FDA approved for major depressive disorder and various forms of anxiety. So they kind of, they really, they are different in some ways, and but their general goal is the same. And there hasn't been one that has been proven completely more effective than the other for various conditions. And as an aside with medications too, with these types of medications, it's less so about which medication is going to have the most effect for me. It's more about trying to find which medication causes the least side effects or matches up well with one's body. And I participated in a seminar whereby, it was talked about what makes for, good effects with medications, what makes for a situation whereby, a patient wants to take their medications. And ultimately, what it boils down to is a patient or a client or a consumer needs to have a good experience with their medications. Not a lot of side effects, tolerate them well, and work well with their doctor to have a good overall experience, a good relationship, if you will, with their medications, to then allow them to stay on them, to then ultimately then hopefully see an effect. Again, benefits of the medications, these kind are felt only when taking medications consistently. They are not an on-off medication. However, there are medications that are taken as needed. Generally, these are for anxiety disorders, not for depression. We don't really have a pill, so to speak, where if you're feeling really, really, really depressed, our patient is really depressed, we can take them and then all of a sudden feel happy. It doesn't really work that way as of yet. However, for anxiety, various forms of anxiety, there are medications out there that you can take, and for a few minutes, few hours, you can feel a sense of relief, temporary relief. Medications that fall under this category, this approach, are things such as hydroxyzine or Vistaril, what are called benzodiazepines, Xanax, Klonopin, Ativan, or Valium. Other medications called propranolol, which is actually a blood pressure medication, but can be used for physical aspects of anxiety to help. And then also another one called Neurontin or gabapentin, although that has other usages as well. Other forms of treatment, in my opinion, just as important, if not more important, if you have the means, if patients have, or family members have insurance or the financial means or the desire to do it, is that medications are important, but therapy ultimately at the end of the day, I think helps with more longer lasting change. And there's various types. There's talk therapy, which is a more traditional form of therapy where one shares feelings with a therapist, discusses relationships, life events, their childhood, kind of that more traditional where you sit and share and the therapist will guide you and direct you throughout that journey. And it can be a little more ambiguous, a little more daunting, but very powerful and very helpful if done well. These are various forms of this type of therapy, but as I said, originated from the classic Freudian therapy, Sigmund Freudian therapy. Cognitive behavioral therapy. This is more specific and structured, otherwise known as CBT. It's generally time limited, about 12 to weeks or so, where it has specific manuals, weekly homework assignments, and it's geared more towards helping people understand their thought patterns and how those thought patterns relate to certain emotions or feeling states, and how that ultimately affects behavior. So a thought could be, I am worthless, CBT for depression, for instance. And the emotion that is tied to that thought of I am worthless is sadness, so to speak. And then ultimately, what are the behaviors that result as a result of those thought patterns? Well, don't interact with people as much, don't take care of myself, don't allow time for myself, et cetera, et cetera. And so this therapy is an approach to try and change behavior, alter behavior by understanding thought patterns and feeling states. It's a little more directed and guided than the talk therapy. Both CBT is used for depression and anxiety disorders. Then there's also something called exposure therapy. And exposure therapy is actually more for things such as OCD or PTSD, but also specific phobias where people, let's say, for instance, they are afraid of heights. They have a phobia of heights. It's geared to try and gradually expose people to different levels of heights, practice, feel the anxiety, etc., to then ultimately overcome that feeling. So the question is, which one, medications or therapy? The simple answer really is both. The combination is generally the best. Typically, research studies confirm that combination is the best. However, there are certain situations where therapy could be a first option, and really that may do the trick. It really depends on severity. So it's not all about the pills. In my opinion, really therapy is underemphasized and really should be overemphasized, but not everybody's ready for it or has the means. But in certain situations, really the combination helps you get to where you need to be. So with that, I will conclude. Happy to answer any questions, and I thank you all for your attention.
Thank you, Dr. Farokhpay. I just want to thank you for your valuable information. It was informative, and I think the information that you presented to us really fills in the blanks. I know for myself, sometimes I've had questions when I hear something or read something, and having definitions and explanations is just very valuable. So I really know what I'm hearing or what I'm reading. So thank you very much.
You're welcome.
At this time, we're going to open the floor and take some questions. What I'm going to do is read the questions from the chat box. So if you have any other questions, please enter them into the chat box, and we will get to those questions as soon as we can. If for some reason we do not get to your question, what we can do is collect them and answer in a follow-up email. So at this time, I'm going to go directly to the chat box, and I'll just start in the order that they were put in here. So here we go. Are we ready, Dr. Farokhpay?
Yes, we are.
Thank you, Monica. I have a question. It says, how can NAMI high school clubs help students struggling with anxiety? Second part, are there any activities that could be done at a tier 1 level? So helping students with anxiety and activities at a tier 1 level.
And just for clarification, in terms of activities at a tier 1 level, because I'm not necessarily familiar with that technical term. If there's any clarification on that, I don't know if there is.
I don't have personally clarification. So Monica, if you wanted to, we can put that question on hold. And if you would like to give us more information, we'll jump right back to it.
I could answer, absolutely. I can answer the first part, though. I will say, especially with in high school setting, especially during COVID now, which we are, multiple study after study has shown increased levels of anxiety, whether it be an anxiety disorder, so to speak, depressive feelings, and certainly in this state of affairs in the world, but outside of that, teenagers and people in high school are going to experience that. I really think, I would say two things. One, unfortunately, social media becomes a blessing and a curse. And I think one of the things that has contributed to worsening anxiety in general, I think I even can feel it in myself, is use of cell phones, social media, comparing oneself to another person's life, this term FOMO that is used, a fear of missing out, so to speak, and looking at things that in some ways can be imaginary, some things can be reality-based, other people's lives, what people post, and really getting people to, and high schoolers to engage outside of social media with each other in person, and seeing if that's really contributing, number one. But more importantly, I would say to really get teenagers in a NAMI situation in high school to talk, to share, to make it okay to share, to provide a forum for people to be able to open up, whether it be in a workshop, a process group, club activities, whereby then one person shares, then another person shares, and then another person shares. Because I think, especially in high school and that age, to fit in, to not feel like you're out of the loop. But I've got to believe that so many people at that age do experience these things, and certainly in the world as it is today. So providing a forum where people can actually share in a non-texting, non-social media way, but actually in person, if possible, or at least on Zoom, but really where they're sharing with their peers and they are showing themselves to be vulnerable, but realizing that other people are experiencing the same thing. I think that's probably one of the most critical things at the teenage level, although I'm not a teenage psychiatrist, officially.
Thank you. Isabel, thank you for sending a question. How can you support a loved one who is experiencing an anxiety episode?
Thank you, Isabel, for that question. Just to clarify, I'm going to assume an anxiety episode, meaning a panic attack of sorts. In the moment, it can be very difficult because, you know, it's almost like a tidal wave that is happening that it's hard to get under control. I think the most important thing you can do in the moment is, one, be with them, and two, if they have as needed medication, if they use medication, then certainly helping them maybe take that medication in the moment. If medications are used or not used, then another thing to do is really to help them breathe, really help get their breathing under control in a basic way, whether it be through deep breathing. People try breathing into a paper bag. Because the problem is, once somebody is in that anxiety episode, it takes on such a life that it's hard to even talk at times, that really what you want to do is slow somebody's body down. It's almost like their emotional state has been triggered, and now it's taken on a physical state where their body feels as if it's out of control. So really, from a breathing standpoint, letting them know that they are safe, you are here, you are next to them, and we need to slow your breathing down, taking slow, deep breaths. That is one of the most important ways to calm somebody's body and then ultimately calm their mind down through that. And to let them know, this is really critical, let them know that the panic attack will be over. There will be a beginning, a middle, and an end. It's not going to last forever. Most people who experience panic attacks in the moment feel like it's going to last forever, that there is going to be a beginning, a middle, and an end. You tell them, this is going to pass. You're going to be okay. I know this sounds very basic and cheesy, but this is very critical in the moment. Very critical. Good question.
Thank you. Great question. Let's move on to the next question. I believe this comes from Lana. How does alcohol use affect anxiety and depression?
Great question. Great question. Well, twofold. One, I think alcohol in some ways is utilized to help offset feelings of depression, feelings of sadness, and dealing with, you know, the weight and heaviness of feeling those kind of feelings day to day. And for anxiety, you know, when I was doing my psychiatry training, one of the professors said, you know, one of the most common, if not the most common form of treatment for social anxiety, at least in our country, is a cocktail, a mixed drink that you know, somebody holds in a social situation at a party, or you know, anywhere to help decrease their level of anxiety experienced by social interaction. So on some level, alcohol is utilized by many people to help keep, you know, social anxiety, even generalized anxiety to some extent, under control, as well as people experiencing recurrent episodes of depression. However, the problem is, ultimately, it can make those feeling states worse. It can compound the issue. Certainly with depression, alcohol over time can have actual biological effects on making people's depression states worse. So in the short term, it might help. In the long term, it might make it worse. From an anxiety standpoint, that's tricky, because I think it does help in some ways, but at the same time can also have ultimate effects as to how one feels their anxiety and how their body deals with the anxiety. So short-term gains probably in both of them. Longer term, however, unfortunately, negative consequences.
Okay, our next question. Thank you very much, Beth, for your question. How does transcranial stimulations work? First part of the question. Second part, is it effective in treating resistant depression?
Another good question by Beth. Admittedly, I am not a transcranial expert, or what's called TMS, but it certainly has gained a lot of traction and become a more utilized tool in psychiatry, which is good, because it's very manageable, it's very reasonable, it's very doable in a clinic setting. And it's, for those who haven't seen it, essentially it's akin to sitting in kind of like a dentist chair, if you will. And it's an apparatus that uses various magnetic frequencies to actually have effects on brain, you know, stimuli and I won't even begin to speak about the technicalities of it because I would be ignorant in doing that. However, it is a generally limited side effect type endeavor. It's not as intensive as electroconvulsive therapy. So that's why I think it's become more commonplace, because people don't experience the side effects. You can be treated in a clinic. You have repetitive sessions, repetitive treatments. And initially it was approved for a major depressive disorder. I know it now has FDA approval for various other conditions as well. However, it can prove, helpful for people who are having recurrent depression. However, I want to also say, kind of going back to what I said, depression doesn't happen in a vacuum. Somebody doesn't just necessarily become depressed for no reason. There are life issues, medical issues, unfortunate circumstances. So to think that, something like TMS can certainly help somebody, it certainly can, but with respect to the other things that are also going on in one's life, whether that be taking medication, using TMS, or what have you, but it has proven effective, and I think that's probably why it's FDA approved for depression.
Great, thank you very much. Just want to let you know, we have a couple more questions, but we've got some time. So if you have any more questions, please type them into the chat and we will get to them. So our next question comes from Dominique. Thank you very much. Could you go into detail on how to support and motivate a loved one with depression? Many end up not trying to use coping skills.
So I'm sorry, my Zoom cut out for a sec. Could you repeat that one more time?
Yes.
I apologize.
Could you go into detail on how to support and motivate a loved one with depression? Many end up not trying to use coping skills.
Well, Dominique's point, I think that one of the fundamental challenges in doing this kind of work is ultimately sometimes we have to force people to get help, so to speak, but that's very rare. And with depressive and anxiety disorders and conditions, it can be very difficult, because if somebody themselves is not in a place, to want to receive some treatment, it can be very hard to sort of force them, even if your intentions are good. So I think you have to weigh those situations. Some people are just not there. They're just not ready for whatever the reasons may be. They feel they don't deserve the help. They've culturally, they're in a culture that doesn't want to show quote unquote weakness or accept mental health services. So there's various factors that can result. I think the ultimate thing always to ask first is, how ready is this person? Are they absolutely opposed? Are they 100%? This is not going to be beneficial whatsoever. And if that's the case, I think suggesting help, offering help initially is important, just so they know you're there. However, if they really oppose it, I think you've got to let it sit for a little bit, because otherwise it can really backfire. And if you try to push, it actually has the opposite effect. Now, to the point about people who are sort of ready for change, or they want to accept some help, I think it really depends on the type of help. I think, are we talking medications? Are we talking therapy? But to let them know that there are various things out there. It's not just a matter of medications or therapy or both, that there are various things that can be done. But I think the real critical question, and it's hard to kind of give a generalization and a general answer, but is asking them, what do they need? Or do they deserve help? Do they want help? And if they do, and there is some buy-in, then you can force the issue a little bit, but really always understanding, where are they at? Are they even ready for it yet? Because if you force too much, it can unfortunately backfire, and you have to give it time. However, if somebody's in danger, heaven forbid, they're suicidal, and it's more of a dangerous situation, then forcing the issue by bringing somebody to the emergency room, bringing them to their doctor and saying, we have no choice but to help you get this help, that's a different situation. But my main message is, as best you can, try and feel your loved one out to see where they're at on the readiness scale to want to receive help, and let them know that there's various types of help. It's not just one or the other necessarily.
So Dominique also added to the question about it. It is truly hard for most to even pick up their phone. So I didn't know if you had anything to add to that comment based on Dominique's first question.
Yeah, I mean, I think, I think if I'm understanding correctly, Dominique, alluding to the fact that you're trying to reach out to somebody and they're not even answering the phone to even try and have a conversation or talk. I may be misinterpreting the spirit of the question, so forgive me, but if that's the spirit of the question, I think it's then a matter of showing up. It's just a matter of showing up and letting that person know that you are here, letting that person to know that you care, you are here, and you're with them in person. I think that's also one of the challenges with our phones is getting very, reliant on texting. People will say, I talked to so-and-so, when in fact it was really a text conversation. That's not, a true conversation. I think feeling somebody's presence, feeling in person, and communicating that message that I care, I'm here to help is different. So if you have access to them, if you're around them, if you live close by or know somebody, but showing up in person, because people, unfortunately, when they're depressed, don't want to do anything. They don't want to pick up the phone. They don't want to interact with the world. They feel too ashamed, embarrassed, too sad to really do much. But showing up in person, otherwise, if they're not picking up their phone in this day and age, then it's really hard to engage.
So we have time for a couple more questions. I just want to point out, Beth wanted to thank you, Dr. Farokhpay, for your answer to her question. She really appreciates that. So Hinda has a question. Thank you, Hinda. Please discuss what is and can be done if one has been told they are treatment resistant to both meds and therapy.
Wow. Well, Hinda, that's it's kind of a tough scenario. Again, some of these questions too is hard. One of the hard things in our work is each situation is also individualized, truthfully, which is different than other fields of medicine where, somebody wants to get treated for high blood pressure or diabetes. I'm not saying that everybody's blood pressure or diabetes is the exact same. However, there is more consistency across the board, but each individual situation in mental health is so unique. So I can't think of the last time hopefully I've never even said that to a patient, that you're treatment resistant. Unfortunately, I think in some ways that could be a labeling of sorts. But again, I'm trying to give an answer to a very generalized question. I personally have never practiced that way and say you're treatment resistant to therapy or medications. But what I will say is I tell patients, there are certain things your medications can do for you and certain things therapy can do for you, and be very real with the limits. But I would say if somebody told, to the spirit of the question, Hinda, that, was told you're treatment resistant, that blanketly, without any clarification or understanding of the specifics of the situation, I would also seek out maybe another opinion. I would also seek out another psychiatrist or another therapist, because also the other point is, not every psychiatrist is meant for every person, and not every therapist is meant for every person. There has to be a matching up of sorts, of styles, of approaches. And so that's also, I would encourage is always getting a second opinion. I encourage my patients to try and get second opinions, because I might be missing something. I might be missing the boat. I might be off. And I ultimately want them to just get help and feel better. So a second opinion is also something I think worth considering. So hopefully that can shed some light on your question.
Thank you. We have just a very limited amount of time. I think I can read one more question, and then we do have a video for closing. So let me read something from Jenny. She talks, and it goes very well with what you just said. Generalized anxiety disorder, does it go away? Is this diagnosis drop off a family member's medical record, but the symptoms still persist? What should you do?
So to the point about does it ever go away? Well, I mean, in the sense of, it really depends, right? I think somebody who experiences generalized anxiety disorder is going to be, somewhat of a worrier. The way I described to my patients is, worrying is natural, as we discussed earlier in the talk, and everybody worries, but people worry to different degrees, whether it be life events that happen later on in life, early in life, or the environment that one grows up in. So worrying is natural. Some people tend to worry more than others, whether it be genetic reasons or life event reasons. So worrying is not something that's ever necessarily going to go away per se, but it can be controlled, it can be relearned, it can be rewired, it can be kept under control. However, somebody probably with generalized anxiety disorder is going to live their life, worrying. So it's not something that's cured per se, that just goes away, because it's your emotions. It's like saying, am I ever going to be in a place where I'm not going to feel my emotions? Well, not necessarily, but with medications, with therapy more so, and other types of things, it can be more and more controlled, where that fire of anxiety, so to speak, gets quieter and quieter. It gets extinguished little by little, and it becomes softer and softer. However, there is potential ultimately for it to rise up again. So it can be controlled, but I wouldn't look at it as a cure so much, where it goes away and it never comes back, because it's a part of you. Our emotional makeup, our emotional states, the way we're wired, to some extent, it's who we are. But we can grow, we can learn, we can change, and we can keep things under better control. But we're not going to fundamentally, flip a switch with medications or therapy and then not feel certain feelings ever again in kind of an absolute way.
Thank you very much. We've sort of run out of time. Remember, we will pose the remaining questions and send out something to you later. So I want to thank you, Dr. Farokhpay, for being with us today. We've gathered some very, very useful information, and I know that each one of us can use what you have given us in a variety of ways. For questions on the content, please feel free to email presenter. For any questions or concerns for today's event, please feel free to drop to email NAMI, California@nami.org. You are welcome to leave the session to move on to the next part of your agenda, but we do have a video for you to watch prior to your leaving. Please take a look at the evaluation survey that will be sent to you at the end of the conference. Your feedback is so helpful to us for our next conference. And please remember to take some time and breaks for self-care. We'll see you in the next session. And thank you, Dr. Farokhpay, for your valuable information.
Thank you all. Thank you for your time.
Thank you so much for attending the NAMI California 2021 annual conference. Now you have the tools in your toolbox to help you advocate every day for yourself or your family. And we'll see you next year in Newport Beach for our 2022 NAMI California annual conference. Thank you again.